All right, let's talk about sepsis, but not like the textbooks do, because on the ward, it almost never looks like that neat table from your finals revision. In real life, it's messy. It's the confused 80-year-old with a temp of 37.9, the patient who's just a bit tacky at 105, but the nurse has a gut feeling something's off, or the one who was fine this morning, and by evening handover, they're drowsy, BP's 90 systolic, and urine output is basically nothing. Welcome back to IMG Doctor Diaries, or if you're new here, this channel is all about what it's actually like working in the NHS as an IMG or junior doc. So let's go through exactly how to handle this on the ward, step by step. Before you jump to cannulas and fluid boluses, start with the basics. Check the News 2 score. That's literally why it exists. It scores things like respiratory rate, oxygen sats, heart rate, BP, consciousness, and temp. A score of 5 or more is a huge red flag needing urgent review. But also, use your own eyes. Is the patient clammy, pale, using neck muscles to breathe? Do they look confused or weirdly calm in that quiet, scary way? Trust your gut, and trust the nurse's gut too. That something's not right feeling is usually spot on. And if the news is high or the patient just looks sick, call your registrar or outreach team straight away. Don't wait for bloods to come back. Sepsis can crash patients in minutes. Start oxygen if they're hypoxic. For most patients, aim and increase 94% SATs. If they're known CO2 retainers like severe COPD, aim 88 to 92% to avoid knocking out the respiratory drive. How to deliver it? Nasal cannulae up to 4 liters per minute gives about 24 to 30% FiO2. Comfortable, but not for very sick. Venturi masks, great for COPD, gives precise 24%, 28%, 35%, 40%. Hudson simple face masks, 5 to 10 liters per minute, gives roughly 35 to 60% FiO2. Non-rebreather reservoir masks. This is your big gun. 15 liters per minute gives up to 85 to 90% oxygen. Use this if they're critically unwell. If they're drowsy or breathing shallow, get an ABG. They could be retaining CO2 or about to tire out. That's when you involve ICU for possible NIV or intubation. Take blood cultures before antibiotics if you can. Ideally 2 sets from different sites. Also send FBC for WCC and platelets, UNEs for renal function and potassium, especially before big fluid resuscitation, CRP for inflammation trend, LFTs and clotting if they're jaundiced or it's an abdominal source, group and save in case they need transfusion, and always check glucose. Sepsis can drop it. These bloods give you the full picture and can help with treatment. Once you've got cultures, start broad-spectrum IV antibiotics straight away, ideally within 1 hour. Every hour you delay increases mortality. We always start broad to stop the infection getting worse immediately. Then, once cultures come back in 24 to 48 hours, microbiology guides you to narrow down to something specific. That's called de-escalation, and it's key to antimicrobial stewardship. Use your hospital's microguide app. Sepsis of unknown source, often tazocin. Chest, still usually Taz. UTI, could be gentamicin, amoxicillin, or other combos. Intra-abdominal, sometimes Taz or meropenem if resistant risk.
If penicillin allergic, check carefully. Might switch to aztreonam or cefuroxymetronidazole, depending on your local protocol.
Start with 500 ml of a crystalloid, like NaCl 0.9%, normal saline, or Hartmann's, over about 15 to 30 minutes, then reassess. Be careful though, too much saline can dilute potassium, hypokalemia, and push up sodium, hypernatremia, causing confusion or seizures. If they have heart failure, watch for crepitations, raised JVP, worsening O2 sats. Could be fluid overloaded. And just by the way, where I work, meds are on the computer, but fluids are still on paper. It actually makes it pretty simple to track exactly what's been prescribed and given. Lactate tells you about tissue hypoxia. If cells aren't getting enough oxygen, they switch to anaerobic metabolism and lactate goes up. Normal is less than 2.0 millimoles per liter. If it's less than 2, start worrying. If it's less than 4, that's severe sepsis physiology. Might need ICU and inotropes. Repeat lactates after fluids to see if they're coming down. If they stay high, escalate. Kidneys are some of the first organs to take a hit. Aim for more than 0.5 ml per kilogram per hour. So for a 70 kilogram patient, that's at least 35 ml per hour or more than 70 ml over 2 hours. If they're drowsy, incontinent, or you just can't accurately measure, discuss catheterizing them. Always chart input versus output. It's one of the best indicators if they're improving. Document everything clearly. When you first suspected sepsis, new scores and observations, sepsis steps and the times they were done, discussions with seniors, repeat lactates and urine output, and your plan. Always follow your local hospital guidelines. Antibiotic choices and escalation cutoffs can vary. Because if, worst case, anything was ever to go wrong, and it ended up in a coroner's court or GMC investigation, clear, thorough documentation means you've protected yourself. It shows exactly what you did and why, and that you acted appropriately. All right, quick recap so it sticks. There's that famous saying, give 3, take 3, to remember the Sepsis-6. Give 3, oxygen, IV fluids, IV antibiotics. Take 3, blood cultures, lactate, monitor urine output. That's your Sepsis-6. Done right, it saves lives. Remember, if in doubt, escalate. It's always safer to overcall sepsis than miss it. Trust your gut, and trust the nurse's gut too. If something feels wrong, it usually is. Drop a comment below. How is sepsis managed where you work? Or tell us about a tough case you've handled. Would love to hear your experiences. If you found this helpful, give it a like. And don't forget to subscribe to IMG Doctor Diaries for more revision-style videos, general IMG advice, and actually, my next video is going to be all about my very first shift in the NHS. Thanks for watching, and stay safe out there.